your attendance. I know I speak for the entire board when I say that we are thrilled to be able to pull this session together for you today, especially in light of the circumstances that we are facing. Now, I will get out of the way and turn it back over to the people you really want to hear from. Be safe, be strong, and be well. Thank you.
Thanks, Steve. Really appreciate you taking the time to share a few words with us and join us this morning. So really appreciate that. And we also have to thank some sponsors because we would not be able to bring you this webinar without the support of two sponsors. We have support from Carl Archer, Elder Law Attorneys, and AARP New Jersey, and we're really thrilled to have them with us this morning as well. And so we will have a few words from Carl. Carl, if you can unmute yourself and welcome the audience, we'd love to hear from you.
Yeah, I'm sure that's something people would really love it if they could just mute lawyers all the time. But lawyers, yes, they unmute themselves. That's how that goes. So I don't want to take more than a minute or two simply because the people that are on this webinar are far more interested. I've had the pleasure of working.
Oh, we're losing you, Carl. We can't hear you.
You cannot hear me at all.
Well, now I can hear you. Okay.
Okay. Yes, it is helpfully telling me my internet connection is unstable, which is great. So anyway, the point is, I am going to talk and then get off, and that'll be so that I can let them talk. But we are a crisis-based elder law firm. We do the work that when people call us, they are at the 11th hour. They don't know what other alternatives they have. They don't know how else to handle the healthcare maze. They don't know what their senior or loved ones or their loved ones with disabilities are going through, and they need help now, and they need a lot of help. And so we have the legal staff to handle a variety of needs from estate planning to Medicaid planning and applications, special needs work. We are capable of going to court. We're accomplished litigators if we need to be. And also we have people on our staff who are specifically, their specific job is to help people with placements in home care settings, assisted living settings, and skilled nursing settings, and to make those transitions as smooth and as uneventful as possible. And you know, the idea is to get them from being caregivers back to being family again. That's the goal. If we can get them back to being family, then we've done our job. And so we would always be welcome the opportunity to help any of your clients or anybody who you know who has a question. And so thank you, Melissa, for the opportunity to let us sponsor these sessions. It's a tremendous opportunity to inform the public here and healthcare professionals, and this is going to be a fantastic program.
Thank you, Carl. Really appreciate you taking the time to join us this morning, and also greatly appreciate your sponsorship. So thank you so much for that. And now we do have a quick video and a few words from our friends and sponsors at AARP. So,
Here are your AARP top tips on caregiver preparedness during coronavirus. During the
Sorry, oops. I think I accidentally paused it. Hold on one second.
coronavirus outbreak, more older adults may need family members to provide short-term and long-term care. Here are 5 ways to get prepared. First, form a caregiving team. Create a list of people in your family and friend network who can help with caregiving tasks. Find organizations that provide services like meal deliveries in your loved one's community. Take an inventory of supplies in your loved one's home. If possible, have a 2-week supply of these items on hand: food and water, cleaning products, personal care products, and medical supplies or equipment. Get medications in order. Make a list of the care recipient's medications and medical contacts. Be sure to have prescriptions on hand and ask the pharmacist for an extra 30-day supply if possible. Over-the-counter medicines for reducing fever and cough are also a good idea, but you should always check with the doctor before giving anyone medication. Make a plan to stay connected. To prevent social isolation, set up available technology to help loved ones stay connected. Schedule regular video chats, phone calls, or texts with family members and friends. Cards and gifts, when delivered safely, can help brighten a day. Finally, maintain your own self-care and safety. Remember to care for yourself while caring for others. Follow the CDC guidelines for coronavirus safety. For high-risk individuals, such as those with dementia and underlying health conditions, consider self-isolating with them. Have a backup plan for care in case you become ill. For tips on caregiving during the coronavirus pandemic, go to aarp.org/caregiving.
Great. So I do apologize. Sometimes with videos, we have some technical issues, and I think it was a little bit choppy, perhaps on your end. So if that video was breaking up at all, we apologize for that. But we do thank AARP for their sponsorship. As many of you know, NJFA is just as strong as our partnerships are, and we're really grateful to not only have the partnership of our two sponsors today, but also of our three presenters, who are all from organizations that we greatly value working with on all of these factors. So just before we get started, a few more housekeeping items. All attendees are in listen mode only right now. You cannot unmute yourself. You're all muted so that we don't have any background noise to distract from our presentations. However, we do encourage you to put any questions that you have in the chat box, and during the question and answer period, we will get to those, and we'll get to as many as we can. In advance, we did ask for questions, so we do have some questions already prepared for our presenters during the Q&A, which we'll be asking, and we'll try to get to all of those as well as the questions that you might have today. And so we do promise to try to do our best to get your questions answered, but if we don't, please do reach out to us and we will connect you with the presenters in order to get all of your questions answered at a later time. So again, we really thank everyone for joining us for the first in this series of 3 webinars that we're doing this month, and very excited to have with us, as I said, 3 panelists who are really going to take us through some very pertinent information during these times. And so we're going to kick it off with Laurie Brewer from the Long-Term Care Ombudsman's Office. Laurie, if you can unmute yourself, and we'll get you ready. I've got your slides here.
Okay, I'm unmuted.
Terrific. All right. So Laurie, you go ahead and get started, and let me know if, as you're going, when you need, if I'm not moving your slides when you need me to, we'll get them all going for you, and then we'll go from there. And please, everyone, do put any questions you have as Laurie's talking in the chat box, and we'll be monitoring that. And when we get to the question and answer period, we will make sure to bring those up. So, so Laurie, take it away.
Will do. Thank you, Melissa. Thank you, Steve. Thanks to the New Jersey Foundation for Aging for this opportunity. One of the gratifying things that has happened as a result of this this terrible crisis is that I really think that the advocates, the elder advocates, have coalesced and are meeting and are talking and are advocating and are lobbying. And I consider among them certainly AARP, firms like your sponsor, Carl Archer, Disability Rights New Jersey. Obviously, Dr. Barile has been a very strong voice as well, really an emerging voice in elder advocacy through this crisis, and value all of those partnerships. So if to get started in my presentation, if you could go to the next slide, Melissa, the mission at the Melissa, if you could move the slide. The mission at the Office of the Long-Term Care Ombudsman, basically it says it right there. We are founded under the Older Americans Act. We are funded in part by the Older Americans Act. There are long-term care ombudsman programs all over the country. We have staff and volunteers who work with individual residents to help them address the challenges they face. We basically we advocate for people in long-term care by investigating allegations of abuse, neglect, and exploitation. Everything we do is resident focused. Everything we do is at the consent of the resident. We are an independent agency in state government. We're located in but not of the Department of Treasury, which is good because the Department of Treasury really doesn't know what we do, so they basically provide us with the administrative support we need, but they don't try to micromanage anything that we're doing. And as an advocacy organization, that's really good. I'm free to provide constructive input to the executive branch, the Department of Health, the governor's office, about things that I think need to be changed. And I think we're all learning that there are a number of things that could be improved in this system. We can move to the next slide. The New Jersey Office of the Long-Term Care Ombudsman advocates for people 60 and over living in long-term care facilities. I should say that the recent reauthorization of the Older Americans Act also gave us the jurisdiction over people under 60, which of course they didn't give us any additional funding for that, but we do take cases for people under the age of 60 if we think that our unique brand of advocacy would be useful to that person. Primarily the people that we're advocating for are in nursing homes and assisted living, but we also have jurisdiction under all of the other types of institutions and long-term care environments that you see here. Move to the next slide, please, Melissa. We have 4 core programs. Certainly our foundational program is our investigations and advocacy. I have 13 investigators who visit facilities and advocate for people by investigating allegations of abuse, neglect, and exploitation. We also have 200 highly trained volunteers who are stationed in or visit weekly about 200 nursing homes in the state of New Jersey. We also receive federal funding through the Money Follows the Person I Choose Home New Jersey program. I have staff who go out to nursing homes and identify people who wish to leave nursing homes and receive home and community-based services under Medicaid. And we also have partnerships with 7 regional ethics committees that do community-based ethic consults for long-term care residents, families, and for facilities. You can move to the next slide, Melissa. To give you an idea of the scope of our work, you can see that we get about 8,500 calls for assistance. We opened 3,500 cases last year. We received a total of 6,500 complaints, and we verified 3,187 of them. I should explain that there are multiple complaints within certain cases. We are an advocacy organization, so we are not a regulator. When we identify a violation of federal nursing home regulations, we refer that matter to the New Jersey Department of Health. If we identify criminal activity, we refer that issue to the Office of the Attorney General for follow-up. And you can see here we made 206 referrals last year. If you could go to the next slide. So of course, everything changed in March of this year. On March 16th, the federal government restricted all visitors to long-term care facilities. That included ombudsmen. So we quickly had to re-engineer how we were going to do our work because our advocacy services were needed now more than ever. So we continue to make phone calls, receive phone calls from complainants, and make phone calls out to facilities. Because I have a very seasoned investigation staff, and because we have so many volunteers in nursing homes, we have very deep contacts in these long-term care facilities. So we know who to call, we know how to get through, and I think that we get good response most of the time from the facilities when the ombudsman calls. Here are the statistics that bear out why we were working 14-hour days during March and April and the early part of May. Calls to the office were up 33%. Case openings were up by 43%. And I have to tell you that it was an exhausting period of time. It was frustrating, but it was nothing compared to what we were hearing from the residents and families. What they were going through was absolutely incredible and heartbreaking during this time. If we go to the next slide, please. Throughout the evolution of this health crisis, the calls that were coming into our intake line also evolved. It really started to hit on March 16th when the visits were restricted. And then our phones were lighting up because families were not able to get into the facility. And they were wanting us to advocate for the facilities to make exceptions. And the federal guidance allowed for there to be like comfort care, and families would be allowed in instances where comfort care needed to be rendered or end-of-life situations. New Jersey actually took a more restrictive view and only allowed people in for end-of-life situations. And there was an awful lot of confusion about what constitutes end-of-life. Is that hospice, or is that someone actively dying? Is that someone who has a matter of days, or is that someone who has a matter of hours? And that type of confusion has pretty much reigned throughout the next 3 months. So we got those calls. Department of Health facilities were taking a pretty hard line on allowing families in. Understandable. I think the families, the feedback we got was, okay, I can accept this. It's for the greater good. We're going to try to keep COVID-19 out of the long-term care facilities. Then the calls started to evolve. Then we started getting calls saying, I suspect it's in there. I think my mom is sick. The rumor mill is running crazy. I hear half the staff is out. There was very little transparency about the existence of COVID-19 in these long-term care facilities. I believe that the Department of Health was telling people in the industry, you need to be more transparent and provide notifications to staff, family members, and residents, but it wasn't happening. And again, our phones were lighting up. On April 4th, the Department of Health did issue some firm guidance relating to notification plans that facilities had to have in place. By then, I think we all recall that the cases were going up. The incidence of widespread COVID-19 in long-term care facilities and deaths was already being widely reported. So events kind of overtook the guidance in this case, I think. But it did serve the purpose of some facilities getting better at notifying families. Then the crisis really took a very dark turn in early April, mid-April. It was when families couldn't get through to anybody. The types of calls that we were getting were, I can't get anybody on the phone. The last time I called there, or somebody called me, my mom was sick, she had a fever, they thought she might have it, they haven't tested her, she doesn't meet the criteria. That's another whole country heard from why people weren't being tested, and they couldn't get through. And in some instances, couldn't get through, because that seemed like that's when a lot of the facilities, particularly in North Jersey, were starting to tilt, staff was getting sick, staff was going offline and being quarantined, and we were in deep trouble at that point. So that's the part where families can't get through. They're pretty panicked and terrified, and we're trying to identify the people that we know in the facility who we can call, because again, we do have deep contacts in the facility. So our role at that point was really connecting families with somebody who can tell them something. And then as the crisis deepened even further, staff were out, staff were sick, many staff have died. We're getting calls from residents saying, I haven't been changed, I haven't been fed, I haven't received my medication for 20 hours. There's nobody here. There's one aide for 60 people. We got calls from staff members saying, I don't have PPE and I don't have any support, and there's nobody here. And I know that facilities are scrambling to get people in there, but there is no cavalry coming. There are people there with, dozens and dozens of people to care for in some instances, and the residents are calling us. This is where you feel very powerless. You can call the facility, we call the administrators, and they're trying, but there just aren't enough hands on the wheel at this point. So I will say that I think that those type of calls have lessened somewhat. Obviously, New Jersey was in the wrong place at the wrong time, the wrong place, close to New York, the epicenter of the pandemic. The wrong time early in the pandemic when there was not enough PPE, not enough testing. And so things seem somewhat better, but there are still many people who are sick. And where we're going now is that families are starting to say to us, look, 80% of the people in this facility have either tested COVID positive or had COVID. Why can't we come in there now that the facility has the proper PPE, now that there's more testing? And, you know, I'm going to discuss for a little bit the federal guidance that has been put out relating to when long-term care facilities can reopen up and allow visitors and family members again. And basically, you need to have 28 days without a positive test. And you need to have adequate staffing levels. I think that's very subjective. I'm not crazy about that provision that the federal government has put in there. But one of the things that concerns me is that I think that some long-term care facilities may meet that phase 3 benchmark sooner than others. And I think there's a concern that if that happens, that people will move from one facility to another so that they can visit with their loved one. But I, from an advocacy position, feel that whenever you get to stage 3 and you can allow families in, that you should do that. If you could go to the next slide, please, Melissa. And so right now where we are is I'm meeting with the Department of Health next week. And one of the things I'm going to be pushing for is for long-term care facilities in the absence of the 28-day benchmark at this point, which I think will be hard for most facilities to achieve, to facilitate outdoor visits. This is happening in other states. They're actually building, you know, temporary structures to allow outdoor visits with family members. So I said that as a result of this crisis, I believe that the advocates are coalescing. I also believe, as is stated in the report that came out yesterday from the Manat Consulting Group, that there is an opportunity here. And obviously this has been a catastrophe in every way imaginable, but there certainly has to be a silver lining. And I hope that is that we will focus on some of the important challenges facing those of us who work in the long-term care space. And so I was really pleased to see in the Manat report, the 100-page report, that a number of the recommendations that I and other advocates have been talking about were in fact in there. So I mentioned that one of the big problems that we had was communication. Families couldn't get information. They couldn't get through to the facility. In some cases, we couldn't get information. So one of the things we emphasized when we met with the consultants a couple or 2 or 3 weeks ago was that you really need to, moving forward, if in future emergencies, and maybe even just as a matter of course, have mechanisms in place to ensure that there is continual communication with families. So by that, I don't mean send out an email that says we have a case of COVID-19. I mean, give information and updates just like any one of us would want if our loved one was in a hospital or in a long-term care facility. How's mom doing today? And I understand completely that as some of these long-term care facilities were really imploding in some cases, that the first thing that's going to fall by the wayside, right, is communicating with residents. And that was why we were getting so many calls. But I think moving forward as any kind of emergency plan, or again, a standard operating procedure, there needs to be an emphasis on continual, meaningful communication with families. Now, I should say that when visits were restricted, the Department of Health issued guidance that stated that long-term care facilities should facilitate phone calls and Skyping and FaceTime. And many of them did a really excellent job with that. But even the ones that were doing an excellent job, once we got into the first, second, third week in April, when things were going really poorly and staff were calling out and getting sick, that fell by the wayside. So there needs to be an ability to keep that kind of communication in place. And certainly the federal government is currently making funding available for long-term care facilities to purchase tablets to have some meaningful kind of video conferencing and communication. And I certainly support that. One of the other things that I harped on, and I'm sure other advocates did as well, is that there really needs to be a hard look, because there's so much public money going into long-term care. there needs to be a hard look at where those dollars are going and to whom they are going. And I think you need to look at the profitability of some of these long-term care companies. And that I was very pleased to see that that was reflected in this report. Now, how that's going to happen, I don't really know. I mean, one of the things that we all agreed on is that the industry needs some, I think, greater regulatory oversight. And the Department of Health really is under-resourced to do that job. And they certainly need to build some capacity, I believe, and competency in the issue of looking at medical loss ratios, or as they are stated, I think it's called a direct care ratio. I think I really support the idea of directing any increases in Medicaid funding toward direct care salaries, and I was pleased to see that in there. I also pushed, and I think this is also somewhat reflected in the report, that because Medicaid is such a huge payer for long-term care in New Jersey, that we really need to incentivize quality. New Jersey has taken some steps in that direction, but they have, I think, have stopped short of restricting the managed care organization networks to only qualified providers. And I think that is something that they still need to look at. And of course, I mentioned the regulatory structure, and I also mentioned to them, and I think Dr. Barile, who's an expert on this, will talk about this, there really needs to be greater emphasis on advanced care planning. I think there was a lot of concern in the beginning that on our advocacy end, that there was a message being sent not to send people from nursing homes to the hospital if they're diagnosed with COVID. Well, first of all, we know that COVID is not a death sentence. It can be treated. There are many frail elderly people who have survived it, because a lot of them have gotten it. Far too many have died, of course. But we were getting reports that there were some such confusion in some of these facilities that people with public guardians, that the public guardians were being asked to sign kind of blanket DNRs for people, which is kind of a meaningless idea in this space, but the public guardian was dealing with those cases individually. I think in the beginning, I think we've all read about this. There was so much concern about overloading the hospitals that I certainly had some concern that people in long-term care would not be sent to hospitals. And I think that did happen in some cases, but in others, I think they were sent to the hospital and they survived. So right now, we're kind of retrofitting how we do our advocacy. I do have federal stimulus money, CARES money, to buy PPE and to buy tablets and to do some other things to try to continue our advocacy in a new way, because I don't know yet when we will be back in these long-term care facilities. My staff is working full tilt, again, doing most things by phone call or by Skype, but we are looking into other ways that we can reach out to residents. So one of the things that we've started doing is sending a newsletter out to residents. And before I jump off here, I want to say that the last newsletter that we did, we emphasized the fact that many, many people in nursing homes are going to be receiving stimulus checks for $1,200. And one of the things that we did was we sent a newsletter out to long-term care facilities, asked them to please share this with residents, informing residents that these funds are coming their way or have come their way. And if they are not shared with them because they are solely at the discretion of and use of the resident, that the facility can't dole it out, they can't control it, they certainly can't take it for back payment, and to call us if they have any of those kind of problems. And we have received a couple hundred calls. Most of them are not problematic, most of them are informational, but we have received some calls. So that basically concludes my presentation here. Anybody has any questions for me at any time, you can always email me there or call I'll also give you my direct line, which is 609-826-5054. If you have any questions or concerns, again, I think there's an opportunity for some real change here, and I certainly hope that we are better prepared if there is in fact another surge in the fall, which I certainly hope there is not. Thank you for the opportunity to address the group.
Thank you, Laurie. Really appreciate the information that you're able to share with us this morning and your time for sure. I know there have been some questions in the chat box, and please don't worry, we are monitoring those. We're going to let our next presenter, Gwen Orlowski, talk, and then we'll take a quick break for Q&A before our second half of the webinar. So, Gwen, if you can unmute yourself, and we'll try to get this working here. We do have with us this morning also Gwen Orlowski, Director of the Disability Rights New Jersey, who's going to share with us the work that they're doing currently and can explain a little bit more about that. So, Gwen, when you're ready.
I'm ready. Thank you so much, Melissa.
Yeah.
I'm going to begin by saying that I too am having technical difficulties. So my internet on my laptop, where I think you're seeing me on the screen, is not really working. So you're seeing me through that, but you're hearing me through the phone.
Okay.
So because the phone seems to be able to better keep the internet connection. So I want to just make sure that, Melissa, it sounds like you can hear me.
I can hear you, which is great. We don't see you, but that's fine. We'll listen more intently.
Oh, okay. So I think you should be able to see me because I'm on twice, but whatever.
Oh, maybe that's
if
good.
you don't see
Yeah.
me. So anyway, so first of all, thank you so much, Melissa and the Foundation for Aging, for inviting me to speak today. And thanks also to AARP and the law firm of Carl Archer. I think this is an incredibly important and timely conversation. And we're really appreciative to talk about the work that we've done at Disability Rights New Jersey. I also just want to take an opportunity to say that was an amazing presentation that Laurie just did. It was so comprehensive. And the amount of advocacy and work that they've done over the last now nearly 3 months is awe-inspiring. So thank you for that, Laurie. I'm going to take a slightly different tact in my presentation. I'm going to focus on the work we've done at Disability Rights New Jersey that is a little bit broader than just long-term care facilities under our jurisdiction. But I'm also going to talk a little bit about how some of the advocacy we did in some of those other areas, I think, can inform advocacy in long-term care facilities. So next slide, please. So one of the reasons I was so pleased that you asked us to speak today is because I think we're an underknown gem in the state of New Jersey. So I came to Disability Rights New Jersey in January of 2019. So I'm still relatively new, and I'm not somebody who comes from a protection and advocacy background. So I've had to really learn about this organization and the incredible advocacy it does and can do. So I thought it was important to talk a little bit about what we are. So we are a nonprofit consumer-directed organization. We have been New Jersey's designated protection and advocacy system for individuals with disabilities since 1994. Before that, we were part of New Jersey's public advocate. So we've existed as an entity, a protection and advocacy system since before 1994. But in 1994, we became an independent nonprofit, and we advocate for the human, civil, and legal rights of New Jerseyans with disabilities. Laurie mentioned the Older Americans Act. Our authorization under federal laws through a series of federal laws that make up the protection and advocacy network. Like the long-term care ombudsman, we are protection and advocacy exists in all states and territories, and the authority we get is first and foremost under the federal law, and it's really significant, sweeping authority and unique in many ways. So we have the authority to investigate reports of abuse and neglect in any setting that an individual who has a disability is receiving services. And that's akin in many ways to what the long-term care ombudsman does. So we get to do that in nursing homes, in developmental centers, in psychiatric facilities, hospitals, sheltered workshops, group homes. I mean, really the list is quite endless. We also have authority to engage in individual and systems legal advocacy. So we represent individual clients, and we can also do systems legal work through, for example, class actions or administrative work or advocacy through policy changes. We also have the authority to do what we call monitoring facilities. This means that under the federal law, we have the authority to enter any facility where an individual is receiving services, an individual with disabilities, and go anywhere in that facility unaccompanied, where an individual who is receiving disabilities might be receiving those disabilities. So the example I give is that we might not be allowed to go into the boiler room of the nursing home, but really any place else in the nursing home, we have the authority to enter unaccompanied to conduct that monitoring work. And in tangent with those three things, we also have broad authority to access records. One of the ways I like to describe our authority is that some of you may be familiar, for example, with legal services, right? So we're in some ways like a public interest law firm. We provide free legal representation to individuals as well as to classes of individuals, but we also have that protection hat that the long-term care ombudsman has to be able to do investigations of abuse and neglect and do monitoring. And this is really unique. Next slide, please. So here are our teams. We do just a wealth of work in institutions, the community, employment, special education, juvenile justice. We have a special representative payee program where under the Social Security Administration, we go into all kinds of institutions, group homes, and even in situations with folks who have individual payees. And we do reviews to make sure they're meeting their fiduciary obligation. We have an assistive technology center, and we do a significant amount of work around voting and recently the census. I want to highlight just two things about our work right now that I think that's relevant to this webinar. The work of our institutional monitoring team, which goes into developmental centers and state psychiatric hospitals and other institutional settings. And one of the things we were just working on before the COVID crisis was conveying to the long-term care industry and to facilities that we have the authority to come into nursing homes as well. You know, if you lose it if you don't use it. I'm not sure that the protection and advocacy was doing that a lot before I came on board, but we are doing it now, and one of our goals is to help the long-term care industry understand that our authority to come into the facility is equal to the long-term care ombudsman. And with all due respect to Laurie, people in the P&A network might say is even stronger because we can represent individuals in a you know, as lawyers in a way that is beyond the scope of most long-term care ombudsman's offices. So to that extent, we've really been working on these access issues. We also have our community inclusion team, and they dovetail significantly with the institutional team in that their expertise is really on making sure that individuals get the services and supports they need in community-based settings and to work to foster inclusion in communities and to help individuals to partner with the folks who do the institutional work to help people move out of institutions. And we've done a lot of work with the long-term care ombudsman's I Choose Home program on that. And I was appreciative that that was one of the focuses of the Manette report. We too talked to Manette, and that emphasis on that New Jersey has made progress when it comes to rebalancing our long-term care dollars, but really still has a long way to go, I think is an important emphasis going forward. I want to just say, I'm trying to be mindful of the time, that we also do end-of-life consultations with the Bureau of Guardianship Services, again, akin to one of the roles of the long-term care ombudsman. And we've been doing significant numbers of those consultations throughout this COVID crisis. Next slide, please. So I'm going to touch on 3 areas of our advocacy during this COVID emergency, some critical issues we worked on, what we call virtual monitoring, and then some of our nursing home specific work. Next slide, please. So on critical issues, one of the things as this unfolded was very quickly how we were going to identify the issues that were so important to the communities that we served. We quickly partnered up with other advocacy groups in our network. So for example, in our work on behalf of individuals with intellectual and developmental disabilities, we partnered with our DD, what we call our DD partners, the Boggs Center, the DD Council, and we did a lot of work with the DDD Ombudsman's office, and as well as with the Mental Health Coalition, and some other agencies to really quickly figure out, find a way for people to get to us the information about what was important to them. And through that, we did a series of town halls, and at the end, there's going to be a slide with our COVID-specific website, and all of those town halls are archived there. But for example, we did one that, since Laurie mentioned it, which is on the stimulus. So if you have questions about the stimulus, we did that in conjunction with the Community Health Law Project, and there's a lot of really excellent information there about the stimulus. Through that, quickly, early in the process, these 2 important issues came up: the issue of medical rationing, or the allocation of critical care resources, and exceptions to the hospital visitation policies, which essentially limited nearly all visitation in the hospital except for certain end-of-life situations. So we zeroed in on those 2 issues really in late March and into early April, and we did a lot of advocacy around those with the Department of Health and with the governor's office. And a lot of the advocacy we did through letters and other work is on our website, and you can go take a look at that. With respect to medical rationing, the state did come up with a medical rationing or a critical care allocation policy. And while it was better than having no policy, it still is problematic. And we did do follow-up work with the state on that, especially around what we see is the discriminatory impact of the tests that they're using to allocate critical care resources. And while that emergency did not arise in April, the policy was never triggered because there was never that critical shortage of ventilators in particular. And we could discuss some of the reasons why that might have happened. And I think Laurie alluded to them. We need to make sure that we get this policy right. And so our advocacy around this continues. And I'll tell you what they've done in some other states is they've filed complaints with the Office of OCR complaints, the Federal Office of Civil Rights. And then those policies have been looked at and changed to make sure that they don't have an unintentional discriminatory disparate impact. And I should say that I don't think that the intent of the policy was to have a discriminatory impact. In fact, I think they bent over backwards to say that they did not want to do that. But unfortunately, I think some of the process that's laid out in there could have that discriminatory disparate impact. We've also raised issues about the meaningful appeals process in that policy, as well as some other issues. We've also done a lot of work around this hospital visitation policy, which the state issued and then issued an initial version and then a second version based upon advocacy of a lot of groups, including, I think, GOCCNJ. And the updated version, which is from May 12th, is also on our website, is better. It allows a person with a disability to have a support person in the hospital. And they clarified that a cognitive impairment includes dementia, that the support person can leave the hospital. The original policy seemed to imply you had to stay there forever. They can leave under certain circumstances and be screened when they come back to the hospital. There is now a provision which wasn't in the first iteration of the policy, that the support person needs to be medically necessary. And I saw somebody raise that question, I think, in the questions that were submitted ahead of time. And that's an excellent question. Who decides that? And that concerns us. That's why initially we advocated that language not be in there. And so I think that that's an open question. And I would say, to the extent that anybody who's having difficulty bringing in a support person into a hospital situation, that they should reach out to DRNJ immediately. We do have some cases around that, and we do individual advocacy should that situation arise. And the last issue I would say about this hospital visitation policy is we're now looking at the application of the policy to other settings, including nursing homes. We've done our preliminary research on that. We think that the same laws that underpin the advocacy around the original exceptions to the policies apply, which are based in disability civil rights legislation. We think that that applies also to long-term care settings, and that the California policies, for example, do extend it to nursing homes. So we're doing work on that right now and hope to get some more done, and we'll be talking closely with the long-term care ombudsman about that. And the last thing I'm just going to touch on real quickly is the stimulus. We've done a lot of work around the stimulus. I mentioned the webinar. Our representative payee project has been in consultation with the Social Security Administration, because those funds were being deposited into the same account for a lot of individuals who receive, for example, SSI and SSDI that their Social Security went into, but the Social Security Administration made clear that they don't actually have any authority over those other funds. We really were appreciative of Legal Services of New Jersey's advocacy around this issue with the state of New Jersey and nursing homes, as well as the Long-Term Care Ombudsman's advocacy, and that did result in the Department of Human Services issuing a newsletter about the stimulus. We're doing some work around that to make sure that's extended to residential healthcare facilities and boarding homes and other settings where individuals with disabilities may be living, to make sure that there's clarity about that. We have a new FAQ about this on our website with our DD partners, the DD Council, the Boggs Center, as well as the New Jersey Division of Disability Services, and we have some new FAQs are going up. So advocacy around this stimulus continues, is continuing. Next slide, please. I'm going to wrap it up. I want to talk just a little tiny bit about our virtual monitoring, because I think that this is so critical. As I said, we typically have a regular presence in New Jersey's developmental centers and state psychiatric hospitals. And when COVID happened in March, we quickly had shut that down. We had actually shut that down in early March. We were concerned that we might be bringing the virus into the facilities. And so nearly from that mid-March point, one of the things we implemented were weekly calls with our state partners in the Division of Developmental Disabilities and in the Department of Health, the part of the Department of Health that has responsibility for the state psychiatric hospitals. And this is one of the issues I raised with Minette when I talked to them, that system was different than it was in the long-term care facilities, that there was accountability and what I like to think of as virtual monitoring with our state partners from the get-go. And I really kudos to the state in DDD and in health with respect to the psychiatric facilities, because they gave us that time, they were transparent, they answered all of our questions. Those lines of communication just were always open. And an example of advocacy that we did there had to do with making numbers public, particularly with respect to the psychiatric facilities, and making sure that that was on the dashboard and people had that information. And I think that those weekly calls led to better results there than our experience with long-term care facilities. The other thing that we were able to institute by mid-April was actual virtual monitoring in the state psychiatric hospitals and developmental centers. And Laurie talked really extensively about the work that they did in nursing homes, and some of the difficulties that happened as we went into mid-April. Well, that was not our experience in state psychiatric hospitals and developmental centers. It took a little time planning in late March and early April to figure out the technology piece of it. The state had issues with, just like I'm having today, with internet and with tablets and with, sort of that technology piece of it. But once we established a system, we were in there starting in the psychiatric facilities and then building out to the developmental centers to provide patients and residents an opportunity to talk with us on a weekly basis. Not all every week, but getting from cottage to cottage, from unit to unit as the time has moved forward. So I think that also was really significant and allowed individuals who were living in the developmental centers and the state psychiatric facilities to have access to protection and advocacy, at least since about mid-April. And I think that's a really important lesson learned, and how we can make sure that is there and in place and robust going forward should there be a second wave. And I'll just dovetail on that, because I do know I'm out of time, that part of what we're working on now is how do we expand that virtual monitoring to nursing homes? Is there an opportunity to work with the long-term care ombudsman? Is there an opportunity to work with family councils, with resident councils, to have our presence available to residents in the nursing homes, like we've been doing in the psychiatric hospitals and developmental centers? Can you go to the next slide, please? And I'll just touch on this real quick. We have done some nursing home specific work, not as much as I would like, but we're turning to that. We have done some nursing home specific investigations and advocacy with the governor. In particular, we're concerned about individuals with disabilities, especially with people with documented serious mental illness and intellectual and developmental disabilities who are in nursing homes, why they're there, whether or not they could be receiving specialized services in less restrictive settings, in home and community-based settings. We're concerned about some of the waivers of discharge protections that happened early on through, that should be CMS, I'm sorry, that's a typo, through CMS and DOH waiver guidance that was put out. And now as we're moving out of that intense period of COVID infection, whether or not those protections really need to be firmly put back in place to prevent unlawful discharges that are unrelated to COVID. And then we continue to do our case advocacy. Next slide. This is just a slide that talks about our website, and you can find information on all the things that I talked about there. And can we go to the next slide? And here's our contact information, and next slide is also more contact information. And I apologize, I know I ran over.
Not a problem, Gwen. Happy to have all this great information that you're sharing with the group. So we are going to take a quick 5 minutes here to do a few questions directed specifically at Laurie and Gwen before we shift over the presentation to Dr. Barile. So I know our NJFA staff member Sue Brooks is on the line, and she's been monitoring the chat box. And as she unmutes herself and gathers some questions, I'm just going to start us off with a question we got in advance, which I'm glad, Laurie and Gwen, that you both were able to bring up the Minette report. And one of the questions we had in advance was if we know what a timeline is for enacting some of those recommendations, and if we know where they might start and what elements of that might be implemented first. And this is particularly timely since we know the Minette report just came out earlier this week. So Laurie or Gwen?
I had to go look for that. I couldn't find it.
So
I wish I could answer that.
So it's just been released, and so we probably don't have a good handle on that yet in terms of a timeline. Yeah. Yeah.
My sense was that they were going to get working on it right away. I just clear to me organizationally what was happening where. And I think we need greater clarity on that right now.
Sure, absolutely. Sue, do you have more questions from the chat box?
Yes, we do. To access technology for residents, there are CMP funds. How does a facility identify their CMP state agency contact to apply for these funds?
Well, I know the contact is in the Department of Health, but I don't know who the exact person is. Does anybody else? I can try to find that information and get it back out to the group.
That would be great, unless Gwen, unless you have.
No, I think that that's helpful. I do want to say that we do have funding to do that assistive technology demonstrations if people need that. And we also have funding to do direct representation, legal representation around assistive technology. So if anybody is asking for assistive technology, for example, if they're on Medicaid and they're asking for it through their Medicaid benefit and they're having trouble accessing it, they can also get in touch with us, because we would do legal advocacy around that issue, around that managed care issue.
Great.
Good, thank you.
Thank you. Before we get to the next question, I did just want to mention that in addition to maybe following up with some of these answers that we don't have at our fingertips right this minute, we will be following up also with a link to a recording of this webinar, as well as we'll be asking our presenters if there is information from these slides that they want to share with the group, if we can share some slides with everyone after. And so we'll get a follow-up email with us from us with some slides, the recording, and a link to the AARP video, since we did have some technical difficulties and folks want to see the whole video. So we will make sure to get that out. But then why don't we, Sue, do you have another question from the chat box we can get to?
Are laptops and PPE that you mentioned available to residents in facilities, or is that intended for your increased needs for your staff?
I think that question probably came while I was speaking about that.
Yes.
The CARES funding, there is, the PPE should be provided in the facility by the facility. I'm looking at PPE so I can get my advocates and my investigators back in there. In terms of the tablets, it's a very good question, because one of the things we're looking at is piloting the purchase of tablets that we can give to selected individuals in the long-term care facility, and perhaps create relationships with social workers or recreational directors to try to help, or activities directors to try to help facilitate some kind of communication with our office and with others in the nursing home, because right now everybody is in pretty deep social isolation in their own rooms and not able to go into communal areas. I don't think I'm going to go out and buy, tablets for every single long-term care facility. I think you saw how many facilities we have under our jurisdiction. But the idea is to try to get them into consumers' hands, into residents' hands. The answer regarding PPE is I think that's the facility's responsibility. I'm looking to purchase it so we can get back in there, because I'm extremely concerned about the lack of scrutiny inside of long-term care facilities right now.
Thank you. Can we as advocates ask someone to go through a facility with a video chat running and have the facility set up virtual meetings for us and the residents?
I think that's a great idea. I definitely think we can do that.
Yeah, and I would say that our first statute, the Developmental Disabilities Act, actually specifically provides that we have authority to be in a facility with a video camera running or with a phone camera running. So we can definitely do it. So Laurie, you and I, we may want to talk more about that. And then I think our broader idea, I think our broader idea also was to be able to figure out a way that we could have communication more broadly with residents through the use of video. Yeah.
And Gwen, does disability rights work with all ages?
We work with anybody who identifies as having a disability. So we don't have any criteria that says you have to have, for example, a disability determination by the Social Security Administration if you self-identify as having a disability. Now I want to say, like Laurie, we have limited resources. We have a staff of about just over 30 and a smaller number of attorneys and advocates. So the scope of our representation can go from advice only through full scope, what you would think of as full representation from an attorney, and that would come into play based on the issue that was being raised. But in terms of having the disability, you simply need to identify as a person with a disability. I just want to say one quick thing on that, because it dovetails into what Laurie said earlier about the Older Americans Act, traditionally 60 and older, and now it can be individuals who are younger than 60. So I was the long-term care ombudsman for a very short period of time back in 2010, and that was one of the frustrations, and we all were like, to whom should we send individuals under the age of 60? And I feel a little embarrassed now. The answer always was to the P&A, because the individuals of all ages are served by the P&A with a very similar authority, as long as the person identifies as having a disability.
Thank you. Has anyone resumed their client CHHA supervisory home visits? And what precautions are you or can be taken to ensure clients and staff remain safe?
That's outside of my wheelhouse.
Yeah, I was going to say, I don't know that that Laurie or Gwen could speak to home visiting, but perhaps we can table that and get an answer on that for that person later. I do want to move on to our next presentation so that we can give Dr. Barile the time that he needs to go through his presentation. So if you're there, Doctor, we can. I will stop sharing my screen so that you can put your video up, and if you want to unmute yourself and take it away.
I've been here. Can you all hear me okay? I do. May I begin with asking a few questions to Gwen and Laurie?
Please.
Yeah, just before I get started, because I also, Gwen, I'm curious, and maybe I missed it, but how many staff do you have in your organization, and how do you get funding?
So that's a great question. So we have 35. Some of the staff are part-time, so I would, and some are pretty significantly part-time, so I would say more around 32. And I'm embarrassed to say I'm trying to quickly count in my mind how many are attorneys and advocates, but some portion of those, 12 to 15, not a lot. Our funding is primarily through the federal government as the protection and advocacy. So our funding is just shy of $4 million, and it's nearly exclusively, our funding is nearly exclusively federal funding under the protection and advocacy line. So there's a protection and advocacy for individuals with intellectual and developmental disabilities, for individuals with mental illness, and then for all other disabilities. And then we have smaller grants to focus on individuals with traumatic brain injury, to assist people with assistive technology, and to do voting work.
All right, that's great. And then I had a question for you, Laurie. Pre-COVID, can you give us an idea of the top 3 or maybe top 5 categories of issues or concerns or complaints that your office worked on?
It's almost always care issues. Failure to follow the care plan is a pretty common complaint. Also physical abuse, and I would say that broadly as rough handling, disrespect, verbal abuse, just kind of general abusive type. Those are the main categories. And then we also do quite a bit of financial exploitation, Medicaid fraud. So that's when family members are not turning over income. We do some of that, but primarily care issues, not following the care plan, and forms of abuse. And they run the continuum from verbal rough handling to actual physical abuse.
Thanks for that. Thanks for allowing me to ask those questions, Melissa.
Not a problem.
Yeah. So shall I get started?
Go right ahead.
And I'll just make a comment too about the Manet report. I haven't read in detail. I'm going to take this weekend to really read it through in detail, but I did scan it, and I was actually, I think it's an interesting idea to look at to scrutinize the profitability of the nursing home industry, but we have to be careful there, because I think that once we start doing that, we're asking the question, is healthcare a human right or is it a commodity? And once we start questioning salaries, then it's a slippery slope, and we've got to ask ourselves, well, what about the salaries of the CEOs that in pharma, or the pharma profits, or the insurance profits? So I think it's a really important question, but we need to ask it of every healthcare sector. And who knows if America's ready to answer that question. And I don't mind saying I'm way to the left on this political opinion. So I'm, but we could talk about that in the Q&A. So I'm Dave Barile, and I'm the founder and medical director of Goals of Care Coalition of New Jersey, and happy to contribute to this webinar. I'll speak for a few minutes, and then what I'll do is I'll do a screen share and show you some slides on two things: medical decision making and the PULSE form. So those are my two sort of main teaching objectives for this section of the webinar, and I hope that they'll be helpful to your encounters with residents in long-term care facilities, and perhaps even in your personal lives. The first teaching point, I'll introduce a 4-step model approach for making medical decisions. This 4-step model is really useful for frail elders or for any person who may be entering into a final phase of life. It's a model that helps obtain important information from the doctors, information that we sometimes don't offer without first being asked. And the second teaching point, of course, is the PULSE form. And PULSE is Practitioner Orders for Life-Sustaining Treatment. And I'm sure many of you are already familiar with this document. It's essentially a single-page medical order sheet that directs care for those entering into a final phase of life. It resembles an advance directive, but there's some very important distinctions, and I'll get to those in my presentation, and also in the Q&A section. I'm happy to better define the differences between the two. So I should begin by welcoming you all to our coalition. New Jersey Foundation of Aging is one of our newest members. Our coalition is a partnership of leading healthcare providers, government agencies, community organizations, and we strive to achieve patient-centered care for those facing life-limiting illnesses, or for those entering into their final years of life. And we essentially try to help align personal goals of care with available therapies. And this nonprofit was created about 9 years ago in response to several reports out of the Dartmouth Atlas of Healthcare. The Dartmouth Atlas is an online publication that measures variations in healthcare utilization across the United States and healthcare spending across the United States. And I'd encourage all of you to look at this website if you have an interest in this topic. It's dartmouthatlas.org. And you can go to the Dartmouth Atlas and you can compare the East Coast to the West Coast. You can compare my hospital system to your hospital system, New Jersey to Montana. And what they found is very interesting over the years. They found in regions of high spending, the health outcomes are worse. And in regions of low spending, the health outcomes are better. And over and over and over for decades now, this research has been out there. And what they've demonstrated over and over, if you go to the Dartmouth Atlas and you put some queries in about New Jersey, this is all, by the way, Medicare data. So these are all Medicare beneficiaries I'm talking about. For seniors, Medicare beneficiaries in New Jersey, you can query the last 2 years of their lives or last 6 months of their lives. And for both, if you're a senior in New Jersey, during those periods of time, during your final 6 months and during your final 2 years, you will spend more days in the hospital, more days in the ICU, see more doctors, see more medical subspecialists, and more Medicare dollars spent than seniors in any other state. So we were last on all of these measures. And so, the question is why, and we don't have time now to get into this, but it's a lot of people that are in the know point to the fact that we have, there's really no single best answer, but we we have a lack of the primary care provider. So there's actually a big crisis in this state that's been looming. We don't have enough primary care doctors, and we have a lot of subspecialists driving medical decision making. So you have the heart person and the lung person and the kidney person, and this frail elder kind of goes from one organ system to the next, and there's no one there to collect it and collate it for them. And also with the hospitalist movement, I think you're all familiar with that. Also, there's a lot of money spent in post-acute care in New Jersey. So the New Jersey Goals of Care is essentially a response to all this data coming out with from the Dartmouth Atlas. So now we find ourselves in this COVID crisis. I've just told you that New Jersey is not a very good place for end-of-life care, and now, of course, we're in the middle or just experiencing this COVID pandemic in New Jersey. We've got over 11,000, last time I looked, over 11,000 deaths, and sadly more to come. And as you all know, nearly half of the deaths are residents of long-term care. So these are really stressful times and scary times for residents, families, and staff of long-term care facilities. I'm sure that some of you out there, many of you out there, are scared right now and worried about your own health or your residents or loved ones in these facilities. You're worried about them, and until recently, until I really learned about this COVID virus and how it behaves, I was also really worried about it. And I want to begin by just talking a little bit about dispelling this myth. Laurie touched on this too, that contracting this virus is a death sentence, and that's simply not true. Most who get this virus are sick with common cold-like symptoms and can get better at home after a few weeks. And this is, of course, on average. This is actually my second day back at work after testing positive two weeks ago. And my symptoms were only fatigue and some backaches for 48 hours, and then I was absolutely fine. So I was really, really fortunate that I had no other symptoms and I had no difficulty breathing. But for some people, for those people who have trouble breathing and need to come into the hospital, most are admitted to a general medical floor. They're given oxygen and a nasal cannula or a face mask. They're given IV fluids and usually discharged after several days or perhaps a few weeks. For some that have trouble breathing, they may be put on a breathing machine or a ventilator. And sadly, as you've heard in the news, elders who are frail and people who with underlying medical conditions that are put on ventilators due to COVID infection have a worse outcome. And most do not get better and cannot come off of ventilators. So if you don't tell the doctors about your preference, either verbally or in writing, then we really don't know what you want as a patient, right? And the default of the system, the medical system, is to do everything we can to prevent death. So it becomes really important that all frail elders have their preferences, or anyone for that matter entering into a final phase of life, certainly the long-term care population, that we have their preferences printed or written out on a pulsed form, so we can align their personal preferences with regards to life-sustaining treatments with those interventions. So I'm giving this webinar now from my hospital in central New Jersey, and as you can imagine, since March we've been incredibly busy, and I've been caring for patients coming in with COVID infections, several from nursing homes and assisted livings, and many cannot communicate and have not provided written instructions. So if someone comes into the ER unable to communicate and in respiratory distress and there's no instructional statement, they will be placed on a ventilator. So if there's time to call the patient's decision maker, then I have to have this very difficult conversation on the phone in the midst of an acute illness. So this conversation is really more difficult and distressing during such a time. So really important that we we plan ahead. And I'm going to do a screen share now and show you some slides. Try to move some of this stuff out of the way. Just take a sec. So I'll start with showing you our coalition slide and all of our organizations. You heard a little bit about our coalition. We're now 20 members and going strong. And again, I want to welcome our newest members. Obviously the Ombudsman also recently joined us, and of course, Foundation for Aging. So I'm going to start by talking a little bit about pitfalls in end-of-life care, and I want to and medical decision making, and I'll begin by talking about these 2 steps. And this is essentially how doctors are trained, how we learn medicine and are trained in medical school and resident education system. So we learn medicine in 2 steps. We learn how to make the proper diagnosis, and we learn how to offer the best possible treatment for that diagnosis. So for example, we'll learn everything we need to learn to take a good history to make the diagnosis of pneumonia, to examine the patient to make the diagnosis of pneumonia, and to order the appropriate radiographic tests and blood tests to make the diagnosis of pneumonia. And then we'll learn, based on all the evidence that's out there, what is the most appropriate antibiotic for this pneumonia based on where this person is coming from, right? So whether they're from the community or from a hospital setting or nursing home setting. And it's essentially 2 steps. So I'm showing you this first because I want you all to understand how doctors are wired. And it's not the fault of the doctor, it's the fault of the medical education system. So we're wired to do these 2 things. Now, there's nothing wrong about just taking these 2 steps. And in fact, it works perfectly well most of the time. And if anyone is sick and we're expecting a cure, we need the diagnosis and we need the treatment. And I sometimes give the example of my own health. And a couple of years ago, I woke up in the middle of the night with confusion and high fevers, and my wife got me to the ER, and my liver function tests were all out of whack, and I was really, really sick. My platelet count was low, and I had no recollection of the tick that I pulled off of my skin a week ago, and I forgot, the doctors didn't find out about that until several hours into the admission. But this was just a couple of days just prior to a scheduled guys trip I was going on with a few of my friends to Colorado. And, I'm in my 50s, very busy, wife and kids at home. There aren't too many opportunities to go on a guys trip. There was no way I was going to miss this trip. I needed that diagnosis. I needed that treatment. Well, it turns out I had something called ehrlichiosis. It sounds kind of creepy, but it's a tick-borne infection. It's like Lyme disease, and it's a very simple diagnosis to make with a blood test, and it's a very simple intervention. The treatment is an antibiotic, and you're better in 24 hours. It works. And so I made that flight, and I made that trip. But the point is, this works perfectly fine, except for people entering into a final phase of life. And it fails that person on so many levels. So let's look at now a 4-step model approach that I think is a more holistic and enlightened approach for that person entering into a final phase. And look what we've done here. We've added 2 steps in the middle. We've added a question about prognosis and personal goals of care. So essentially, this 4-step process is a model for, number 1, scripting the conversation with the doctor and the patient, right? And also a model for actually ordering tests and making decisions in the big picture of what would be helpful in terms of achieving that person's goals. So the first step is obviously, what's the diagnosis? We need that. The second step is, what is the prognosis? doctor, what can I expect in the next 1 year or so? Or how long will my mom live with this intervention? Or will I be able to live independently? Will I be able to eat? And so on. Tell me about the time. Tell me about the quality of that time. Tell me about the dependency on others during that time. So doctors have this information, but this is an information that we willingly share in conversing about this stuff. But if you ask and press doctors, then we'll be able to, we often can volunteer some of this. And then the third step is, what are the important things for that person? What are the personal goals of care in the context of this prognosis? In other words, I've just told you, mom is entering into the final weeks of months or final year of month. Well, what's final year of life? What is important during this final year? Where should she be? What kind of intervention should she have? And I've heard so many different requests. So this is where it gets personal. And then the final step, step 4, what treatment modalities are available to help achieve those particular goals? So aligning personal goals of care with available treatments. So, and I'll give you an example of how this can be applied. And this was really instructive. A couple of years ago, I was on a teaching service and I had the young doctors in training with me, and we were working in the hospital, and I had the resident doctor and the interns and the medical students. And within 1 week, we had 2 healthy, high-functioning elders in their 80s come in from the community. And both of them were living independently, driving, and both had the exact same diagnosis. Both had a really terrible stroke that left them hemiplegic, couldn't move one side of their body, and couldn't swallow. Both were awake, had trouble speaking, but they could understand what's going on, right? So we talked to them about the first patient came in, a gentleman. We talked to him about his diagnosis. We talked to him about his prognosis. We shared with him that he would not be able to swallow, that he needed a feeding tube, maybe temporarily. This feeding tube perhaps could come out after a few months if he regained the ability to swallow. We told him that he would be dependent on care moving forward, that he could maybe transfer in and out of a wheelchair, that he would need rehab, that his life could perhaps he could live several more years, but would be dependent on others. And also the chances of having another stroke were high. This man had been married to a concert pianist, and she had since died, but what made his life worth living, what he enjoyed most throughout the day, was listening to her recorded music. This man woke up in the morning, turned the music on, turned it off, and went to sleep. And that's how he went about his day. He really found pleasure in listening to this music. So this man decided to have the feeding tube placed, and he got full court press, and he actually ended up hiring 24/7. He had the funds to go directly home. And he hired the support staff to go home with the feeding tube, and he was able to listen to his wife's music. And this is what made his life worth living. And so his treatment was the feeding tube and home care with physical therapy. A few days later, on paper, it's the same case, right? The same patient. A woman came in. She was high functioning. She was actually a retired botanist at the university, and she was an avid gardener. And I would pass her home every day going into work, and I would see her vigorously gardening in her front yard and so on. And her goal, when we shared with her this same prognosis, and we told her that maybe with one hand she can do some potting, but it would probably be in a nursing home setting or with help. We talked to her about this prognosis, and she basically asked, well, what else you got? Because this isn't satisfactory to me. And we talked about palliation also, and we talked about hospice, and she elected hospice care. So same diagnosis, same prognosis. Her goals of care, understanding what her prognosis was, to just be comfortable at home and die a peaceful death at home. A PEG tube would not help her achieve that goal. A rehab referral would not help her achieve that goal. A neurology consult, an MRI, a statin to bring her cholesterol down because she just had a stroke would not help her achieve that goal. The treatment modality was the hospice referral. So that was step 4. So now you can see how important it is, I think, for this 4-step model as opposed to a 2-step model. And we have on our website, goalsofcare.org, we have a lot of material applying this 4-step model. And we have something called an iCare plan that we've printed up. That's essentially like a notebook or a cheat sheet for the 4 steps that a decision maker can use while speaking with a doctor. We also have a companion pamphlet for the practitioner that's helping script this conversation. We also have a lot of information, I'll mention this at the end, on the Pulse Forum in a lot of different languages and some really good instructional videos. So after this webinar, I'd encourage you to please look at goalsofcare.org. And so let's now talk a little bit about the Pulse Forum and where the Pulse Forum fits in on this decision-making process, right? So we've shared information, or at least the patient or decision maker has an understanding of the diagnosis and prognosis, has an understanding of that I myself am entering into the final months or final years, or my loved one is entering into this final period of time. I need to complete the Pulse Form. Well, the Pulse Form is able to capture the final 2 steps. So on the Pulse Form, we write what the goals of care are and what the treatment modalities are. And in the first section of the Pulse Form, section A, which is actually not an order section, the first section begins with personal goals of care, and then the remainder of the Pulse Form is actually treatment modalities to help achieve those particular goals. So now we'll officially kind of launch into our Pulse portion of this section of the webinar. And I should mention first that pulse.org is the national website where the National Pulse Paradigm lives. And the National Pulse Paradigm is an effort to help states develop their individual pulse forms. And it's a challenge because every state, because advanced care planning laws change from state to state, each state need to come up with their own pulse forms. And to make matters even more confusing, not every state calls it pulsed. Some, like New York, calls it MOLS, Medical Orders for Life-Sustaining Treatment. Some, Delaware, I think, calls it D-POST, P-O-S-T. But if you have an interest, if you have family members or loved ones outside of New Jersey and you want to find out if that state has a pulse form or if it's up and coming, go to pulse.org. And each state has a different color of their form too. But I just want to begin by pointing that out. And there is reciprocity across states. So if someone from California shows up in my emergency room with a California pulse form and it says, "Do not resuscitate," I may not resuscitate that person. And likewise, if someone travels with the New Jersey pulse form to other states, there is reciprocity. But for purposes of this webinar now, we'll focus in and drill down on the New Jersey pulse form. And it is housed and distributed by New Jersey Hospital Association. And I'll remind you of this website at the end of the presentation, njha/pulse.com. New Jersey Hospital Association is the entity that created the Pulse Forum and is responsible for Pulse distribution. I'm on that Pulse task force, and with the help of Goals of Care, we help design and structure the form of the form so that it actually is a script for having the conversation, and I'll point that out as we go through the form. So what is the Pulse form? It is essentially a set of actionable medical orders. It's just like the doctor writing, "Check the vital signs, Q shift," or "Take this pill twice a day." It's a set of medical orders that must be followed that represent end-of-life choices for that resident, for that patient. The Pulse Form is a complement to the Advance Directive. It is not intended to replace a living will or instructional statement. And there's only so much we can get on the pulse form. So one should complement the other. And yes, you may have both. You can have a written advance directive or living will, and you may also have a pulse form. It's really important that the surrogate decision makers match on both of those forms, right? You don't want the son on the living will as the healthcare proxy and the daughter on the pulse form as the healthcare proxy. So they've got to be the same person. It's in a brightly colored format, and this is the color for New Jersey. I apologize for that awful green color. It's sort of silly that we decided on colors. The reason why many states ask that the pulse form be in a bright color so that when the EMTs come into the house, they could easily recognize that brightly colored form on the refrigerator door. Or when you're looking through the chart, you can easily find that green form. Well, the law is pretty clear. It does not have to be in green. And I've said this over and over, and I'll go on record. Put it in black and white, because doctors still use fax machines. And when you fax this green form, it comes out the other end too dark to read. Or if you try to make a copy of it, it doesn't come out. So we should try to make the first form and the original form in green, but it usually creates some problems. So a black and white version is perfectly fine, and you may use a black and white version, and that's what I usually recommend to people. Really important feature of this form is that it is portable across healthcare settings. So what do I mean by that? That means if I'm in the hospital right now, and after this webinar, I'm going to go see some folks and do some palliative medicine consults, and if I get the opportunity, I'll complete a pulse form if this person is leaving the hospital, right? And this pulse form, once completed in the hospital, is an actionable medical order. So if it says do not resuscitate, then we may not resuscitate. When this person leaves the hospital and goes by ambulance or transport to the nursing home, that is an actionable medical order in the ambulance ride over to the nursing home, and on the medical order chart or in the system in that facility, it's an actionable medical order and does not need to be rewritten. If that person goes home, it's an actionable medical order on the refrigerator door, and that's usually where it's kept, by the way. That's usually where the first responders look. But that first responder, if they show up in the home and they find a person without a pulse, without a pulse or blood pressure or breathing, they're dead on the kitchen floor, and they see that form there that says do not resuscitate, they will not resuscitate. If that person has a living will, and this is the distinction between a living will and a pulse form, if there's just a living will there that says keep me comfortable, well, the law is they've got to attempt CPR unless there's a medical order. And that's the importance, and that's really where the power comes in with pulsed. Pulse is a medical order that they can respond to. They can't respond to a living will. So, and again, this pulse form, if they end up coming back to the hospital, is still an actionable order, even if they go back to a different hospital where I don't have privileges, or an out-of-state hospital, it's still an actionable medical order. So the portability of pulse is a really important concept for you to understand. So who is the pulsed form intended for? It's really intended for, and built for those people entering their final years of life. And elders or residents of nursing facilities or assisted living facilities. Most people in the advanced care planning business would agree on these two statements, that this is really the population for pulse. It is not intended for healthy adults. It's intended for those people who may be entering into a final phase of life. So who completes it? Remember, it's a medical order. It's a medical order. So it can be completed by a physician, a nurse practitioner, or as of last year now, a physician's assistant in the state of New Jersey. These are the people who may complete and fill out a pulse form for a patient. And the consent is, of course, from the patient, if the patient has capacity. If the patient does not have capacity, then it may be completed by their decision maker or their surrogate decision maker. So this means that people with cognitive impairment, people with dementia in a nursing facility may have a PULSE form completed for them on their behalf, right? That person who lacks capacity cannot do a living will, right? If you want to do a living will or advance directive, you need to have capacity to either go to an attorney or go online or go to a social worker or a friend, right? Because in the state of New Jersey, you don't need an attorney to fill out a living will. You can just download it online, and you need 2 witnesses, notarized, or an attorney can sign it. But you need to have capacity to do that. For the PULSE form, someone with capacity can fill out the form with the practitioner, or that person who lacks capacity can have their surrogate complete the PULSE form. Now, this has been true pre-COVID, and it remains true. Verbal consent is allowed. So if I have a decision maker who happens to live in California, and mom is here or dad's here in a nursing home or in the hospital, and the decision maker's in California, I can call that person up and get consent and fill out the PULSE form, and then write verbal consent obtained. I could also, and I've sadly had this experience before, if someone's dying in a hospital bed or in a nursing home bed, and they can have this conversation about what they want and don't want, but they can't lift their hand to sign the paper, you can write verbal consent obtained. Sometimes when we do this over the phone, some people feel more comfortable getting witnesses over the phone, so you can hand the phone over to a nurse or colleague, and they can confirm the conversation that so-and-so is requesting X, Y, and Z on the PULSE form, and then you write verbal consent obtained with the witnesses. The law does not require you in New Jersey, by the way, to ask for a witness when you do a verbal consent by phone. There are some states that do require a witness. So let's go through actually completing the PULSE form and each section of the form. The upper topmost section is simply the person's name, date of birth, and address. It's just the demographics. Section A is actually not part of the order set. The order set begins section D and on down, but section A is perhaps one of the most important sections of the form, and that is the goals of care section. And it's the answer, we write here, the answer to that question, what are your hopes for the future? Now that you understand what the prognosis is, what's important to you during this time? And I've had all kinds of things written in here. So to remain independent, to make it to a 100th birthday, to make it to a graduation or bar mitzvah, to die a peaceful death at home, to get the heck out of the hospital, to have a certain type of music playing during my death at home. People can write all sorts of things here, but that's a personal thing. This is where it gets personalized. The really important thing to emphasize here now is that whatever we write in the remaining section of this PULSE form now, in terms of the order set, should reflect and respond and align with what we write in the goals of care section, right? So it's following that 4-step wise approach, and it's aligning personal goals of care with available therapies. So let's look at the order section, and there's a lot of medical mumbo jumbo in here, and you can, on your own time, you can look more closely at this stuff online if you'd like. But yeah, section B is a little complicated. I'll just highlight the main features of section B. It basically asks about scope of care. And there are 3 options or 3 boxes to check off here. You can either check off full treatment, which means we're going to do everything we can within our range of possibilities here to fix this problem, either medically or surgically or with the intensive care unit and so on. It means you would come back to the hospital, you would go up to the ICU if needed, you would have surgery if needed, and so on. We're going to do everything we can to get things done. The next option is limited treatment, or kind of middle of the road options, and use appropriate medical interventions, but to a certain extent or degree, and try to avoid ICU care. And under this limited or middle of the road option is a question about you returning to the hospital. So if we check off limited, then there's a second question of, do we transfer to the hospital for medical interventions if we can't take care of your loved one here in the nursing home, or avoid the transfer to the hospital and only go to the hospital if comfort needs cannot be met there? In other words, if someone's writhing in pain or having a seizure or intractable nausea and vomiting, and we just, even in a hospice situation in a nursing home, right? If our goal is to provide comfort, if we can't get them comfortable there in that setting, we have to up the level of care and bring them into the hospital to get them more comfortable. So that's the first, and there are two, that's the first spot on the POLST form where the do not rehospitalize order lives, okay? So right here is the first do not rehospitalize order under limited interventions, but only go back to the hospital if I can't keep the patient comfortable. And I have to say, I have, in my private practice, I take care of a lot of people. I'm also a nursing home doctor. I work in the hospital setting, overseeing hospital geriatrics and palliative medicine services. But the second half of the day, I work in the nursing home setting and assisted living setting. And over the years, I've had many patients tell me, just do the best you can for me here in the nursing home. I don't want to go back to the hospital. Or family members also ask me that, because we can do a lot of things in the nursing home setting. We can do IV fluids, we can do oxygen, we can do labs, and so on. And some people, particularly people with dementia, their loved ones don't want to have them burdened, to go back and forth to the ER because it's, cognitively disruptive, and there's agitation and so on. So there's the first DNH, or do not rehospitalize order. The second one is the third option in section B, and that's symptom treatment only. So symptom treatment only, if you check this box, is essentially asking for hospice-like care. Anybody who is enrolled in hospice has this box checked, because when you're treating symptoms, that means you're only giving interventions and medications for symptoms like pain, you get the pain pill; nausea, you get the nausea pill; insomnia, agitation, and so on. You get these interventions to alleviate suffering. No blood tests, no x-rays, no IV fluids, and so on, just comfort care. And also there you have a do not rehospitalize. So that's section B, and that's really kind of a big part of the POLST form. Full interventions, limited interventions, symptom treatment only. Then there's a section on artificial nutrition and hydration. There's a section D on resuscitation. And in New Jersey, we've separated out cardiac resuscitation on the left and then pulmonary intubation on the right. And it's sort of silly that we've done this, and any ICU doctor, cardiologist, or pulmonary doctor will tell you, it's, if you're going to do one, then you've got to do both. You can't just do one and not the other. But that's a whole nother story to that. There we have it. We've got two options here on the resuscitation, and whether to attempt cardiac resuscitation and whether to use a breathing machine. And this is really an important section, particularly in times of COVID, because we know, sadly, that frail elders do not survive COVID if they reach that point where they require mechanical ventilation. I've had plenty of patients in my nursing home survive COVID, and I've had plenty die. And we lost, in my nursing home of 110 residents here in Princeton, we had 20 deaths during this pandemic thus far. Now everyone is sort of settled now, and we're through this crisis mode. But of those, I think one or two made it to the hospital on a ventilator. But in my experience here at the hospital, very sadly, we've had many frail elders come in from the facilities with no advanced care planning, and not enough time to have this conversation with families, end up in an ICU setting on a ventilator, and then after a week or two or three, need a terminal extubation off the ventilator. So we can talk during the Q&A about chances of surviving CPR, but I will mention just briefly now that there's a very common misconception in America, and even in some medical communities here that CPR works. And that's because CPR works on drama shows most of the time. And in fact, there've been a couple of studies that looked at surviving CPR on television, and it's something like 80%. So if you're watching a TV show and during the show somebody receives CPR, well, 80% of the time at the end of that show, that person will go home fine. Well, when you ask the general public and even the elders, what do you think your chances of surviving CPR? They'll say, oh, about 80%. And that is so off the mark. So in reality, for that frail elder, it's more like 5%. For a nursing home bedbound elder with dementia, it's much less than that. And if you're in that population and you have COVID, it's essentially 0. So I know that's a sweeping statement there, but and I'm generalizing a bit, but it's really important that we improve health literacy around CPR and intubation. It's really important that and in fact, this is why we built the Pulse form the way we built it. It's important that we talk about what interventions will work and what interventions will not work. So we built the Pulse form in such a way that in section B, you can check off full treatment. And yes, I'll do everything I can to get you better. I'll send you back to the hospital and we'll do these interventions. But I can also reach down to section D and check off do not resuscitate. In other words, so that empowers me to have this conversation. I'm going to do everything I can to get mom better. I'm going to do everything I can to get you better, right? Short of things that aren't going to work. So we can try the ICU, we can try these interventions, but if the heart stops, let's allow a natural death, because attempting CPR or putting a breathing machine down would only prolong that dying process and not save your mom's life, but just simply postpone the death. So let's keep going here. Section E on the Pulse form is actually, I refer to it as Governor Christie's section, because he conditionally vetoed, or his staff recommended vetoing this Pulse bill unless there was language in here that essentially section E asks the patient, right? And if we only complete this section if it's the patient completing the Pulse form with the practitioner, not the surrogate. If the patient has dementia, we skip this section. But if the patient has capacity, we ask them, is it okay if when you lose capacity, your loved ones or your surrogate changes this form in consultation with the doctor? And I have to say, about half of my patients, and I've done hundreds of these, about half are saying, oh, absolutely, it's perfectly fine, they can change it. The other half are saying, no way on earth are they ever touching this form, because they all have different opinions and they're all crazy or this or that. So in both situations, I recommend the same thing. Let's make a bunch of copies and give them out to your family members so they see what you've written here now. And then finally, there's a section for signatures, and the practitioner signature goes on the right. The decision maker signatures goes on the left. And if it's a verbal consent, then on the left, we write verbal consent obtained by so-and-so. And then finally, there's at the very bottom of the form, you have the surrogate information. So just finishing up now, what should you do next? I can, again, recommend these websites, pulse.org. If you want to learn a little bit about the national effort, you can check out pulse.org. You can also look at NJHA. There's some resources there. If you're a medical professional, there's a webinar there that I've done for scripting this conversation. And then I'd really encourage you all to look, take a deep dive in the goalsofcare.org website. So we've got a lot of really good videos there. We have videos on the 4 steps. We've got a really nice introductory video and then follow-up videos on the Pulse form, just a couple of minutes long. And what I do now in my practice, I refer people to these videos before I even have that deep conversation with them, right? And what I've found is that it shortens the duration of the time that I spend having these family meetings, because they come in more health literate and understanding what the Pulse form is, what the 4 steps are. And I ask them, I say, hey, look, we're going to talk about this form tomorrow, the Pulse form. I'd like you to go online and watch a few videos about it, learn about it, so you come in better prepared. So it's been a very efficient use. If you have questions, about getting involved in goals of care, Jessica Brown is our operations manager, and she can respond. And I'm sorry I didn't, others put their personal website, their personal email. Mine is D-B-A-R-I-L-E, and you can see how my name is spelled there under my, at the bottom there of my video. My email is dbarile@goalsofcare.org. And a really important point to finish with, you need 2 signatures, or you need 2 parties for this pulse form to be actionable. It cannot just be signed by the decision maker or just the practitioner. You need both parties signing. So I'll thank you now and end the show, and we'll see if I can stop sharing.
Yeah. Great.
And thanks. I think we've got 9 minutes remaining, down to the wire, Melissa, but hopefully that was informative.
It was very informative, and I really appreciate you taking the time to be with us today and for sharing that information. And yes, we do have a few minutes here for questions, and I'm going to ask again, Sue, if you could unmute yourself and let us know what questions you've got there in the chat box. I do suspect that we have a lot of questions for Dr. Barile about, in particular, the post form. As I was looking briefly at the chat, there seemed to be a lot of questions about that.
Indeed, we do. The first one, though, is a comment from a bedside ethics consult manager who said that with COVID-19, there's an influx of patients from nursing homes with no advance directive or POLST or NOK, and the process to have a court-appointed guardian put in place delayed good care. So just want to make comment of that.
Mm-hmm.
And then
that predates COVID. I mean, we've had that, but it's certainly exacerbated.
Okay.
Yeah.
And to whom do I give the POLST form to make sure it gets in someone's file?
Right. So once the POLST form is completed, it should remain with the person, the patient, right? So if that person is in the community, that person should have a copy at home. Doctors, important doctors, primary care doctors, consultants should have a copy, and loved ones should have a copy. Unfortunately, there is no POLST. New Jersey Hospital Association has built a POLST repository, and they're expanding it now. I think it will be a few years before it's up and running and accessible to all. And sadly, a lot of hospitals are not storing their POLST forms, but if your local hospital does have a registry, you can give it to their medical records. If the person resides in an assisted living or nursing home, it should be on that medical record. So most facilities, all facilities, understand that the POLST form must go with the patient if they're transferred to the hospital, right? So they go with the demo sheet, and they go with the POLST form and clinical, medications and so on. Hopefully that answers the question.
Thank you. And this one says, my mom has both a primary care and cardiac doctor, but they don't work together. Which one would complete the form?
Right. So it's hard to find a doctor to complete the POLST form. The doctor that knows the patient best, perhaps, and the doctor that feels, or the patient who feels most comfortable. Some will do a better job than others, sadly, but either can complete the POLST form. It's really, ideally, most would suggest it's up to the primary care physician to complete the POLST form. And additionally, that person can bill Medicare now for that service of completing the POLST form. It's an extra, I think it's about $85 they can, in addition to their regular office visit. So there is an advanced care planning code that clinicians can use now that hopefully will incentivize more doctors to do it. But the short answer is the primary care doctor really should be doing this POLST work, but sometimes people have a closer relationship with their cardiologist. That's an individual decision.
Thank you. And from my experience in long-term care, some confusion about Section B on POLST. Some believe that unless "do not hospitalize" is written on the form, the patient will be sent to the hospital. Do you recommend writing DNH on the form in this section if that is what the resident wants?
It's interesting. I often, now that I hear this, I often find myself writing "do not hospitalize." Technically, you shouldn't have to write that, because if you read carefully and if you check the box carefully under limited, if you check that second box, avoid hospitalization, or if you check symptom treatment only, the very last line reads, transfer only if comfort needs cannot be met in current location. So the DNH order is in there, but I will confess to you all that the DNH order is hidden on the PULSE form. It's not so obvious. And with the next iteration of PULSE, and I've brought this up to the committee a few times, I think the next version of PULSE hopefully will have that in more obvious language, or a second obvious box to check off. But I found myself actually writing in "do not rehospitalize" in addition to checking those boxes.
Okay. And should the PULSE form be put in residences' files at nursing homes?
Yeah, and that's where it belongs. If someone resides in a nursing home, it belongs in their medical record on their chart. Yes.
Okay, thank you. And let's see. The first time my elderly father and I encountered the New Jersey PULSE document was when he was in the ER at a VA hospital. My father is in end-stage renal failure, but this wasn't a life or death event, so it was confusing and frightening. When is the best time and what is the best way to gently approach end-of-life issues such as NJ Pulse, DNR, 5 wishes, etc.?
Right. So the two words "end stage," right? End stage renal failure. So that's a chronic condition, and sadly for people with dialysis, depending on the age and other comorbidities, most people on dialysis are entering into the final years of life. And again, that's a sort of broad statement. But when is the best time to bring this up? Sadly, not in the emergency room, right? And not in the ICU. So we need to have this conversation more upstream in the course of illness. So we need to begin having, I'll go as far as saying, we need to begin having this conversation as early on as high school health class, and people need to be, young people need to understand and be empowered to understand that their bodies are their own. And you can accept and reject any medical information or recommendation by doctors and clinicians and so on. And that should begin very early. And very early when we're healthy, all healthy adults should have an advance directive. I have an advance directive. My wife knows where it is, and I've had to, on a few occasions, talk to her about it. So we should all be having this conversation earlier on. But particularly important when people are entering into their final years of life, that conversation should be owned by the primary care provider. But sadly, we have a very fragmented approach to this. Oncologists often take over the care. Someone's really sick, and then they see their primary care doctor for years and years, and then in their final years of life, they're seeing specialists now because they have a specialist problem, a heart problem, or oncology problem. And then those doctors kind of own the conversation. And no one's having this conversation. We are terrible at this. Why? Because we don't learn about it in the we don't learn about this stuff in medical school or residency training programs. And it's a language we don't know how to speak. It's like asking them to speak Mandarin if they don't know how to speak Mandarin. We just don't have the skill set. So in a perfect world, we should have this much earlier in the course of the disease before somebody enters the ER.
Thank you, Dr. Barile.
Yeah.
And Melissa, I have
Yep.
another question for the other speakers as well.
Yeah, so this will have to be our last question because we're almost out of time. But yeah, go ahead if you would ask that question, please.
Okay. Have outside visitation stations been approved for LTC facilities in New Jersey? If so, is there a letter of proof available for our use?
I think I'm going to take a shot at that. If somebody else has a more concrete answer, and certainly welcome it. But I've actually asked for a meeting with the Department of Health next week to discuss this very thing. I know that other states have done that. And if there may be people from the industry who are on the line who are already doing it, but I'm specifically going to be asking if the Department of Health can issue guidance on this issue, because we have this opportunity with the nice weather, assuming we don't all get blown away in one of these terrible thunderstorms that we're having, to really connect people again. So I hope to have more information on that in the next week or so.
Yeah, and I'll add to that, in our local nursing home, we're beginning to build one now, and hoping that we'll hear something solid from the Department of Health. And but we're actually not waiting. We're starting to build it, and it's tough because we have to follow, and this is part of the big problem with the response in New Jersey, that we're reporting to our local Department of Health, and it's a sort of very fragmented system of information sharing. But Laurie, if you can press them to come out with a clear statement, that would help so many.
Yeah, I think so too. And the other thing that we're going to be pushing for is more family visits, as I mentioned earlier, or designating a support person or one person from the family who can at regular intervals access the facility. I am very concerned about the phase 3 approach of not having families that go in until a facility is 28 days free with 0 positives.
Yeah, and what they're doing in Belgium, sorry, Melissa, I know you want to wind up, but I can tell you that in Belgium, they asked that just one family member come in for, each resident has one relative.
Exactly.
So they don't have a lot of different people coming in.
Right.
It's just one assigned person, just to
that's what we're looking. I'm looking for that, and the Long-Term Care Coalition out of New York are pushing that as well.
No, that makes sense to cut down on the, the spread, cut down on the impact by having
the traffic.
Yeah, exactly. Yeah. The traffic. Thank you. I couldn't find the word I wanted to use. So we are at time, and I do want to be respectful to everyone's time and wrap this up. I again want to thank all 3 of our presenters, Laurie, Gwen, and Dr. Barile. You've been excellent in providing information to our audience today, and we're really grateful for your time. Also, again, want to recognize our sponsors, Carl Archer Law Office and AARP New Jersey. As I said, we will be sending out a follow-up email with links to information that was presented today, as well as the video from the from AARP and some, the recording of this webinar as well for all of you. We're really grateful for all of you that have tuned in and joined us today for this, and want to remind you that it is part of an ongoing series this month, and we have 2 more webinars coming up in June. Next Friday, we'll be hearing from Katie York with Lifelong Montclair and Janelle Rodriguez from the American Friends Service Committee, who are going to be addressing both the impact and the response that age-friendly communities have had, as well as the impact that COVID has had on immigrant families. And so we're really thrilled to hear from both of them. And then wrapping the series up at the end of this month on the 26th, we'll be hearing from both Charles Clarkson with the Senior Medicare Patrol and Frank Winter from CMS about benefits, changes to Medicare, as well as alerts for scams. And from Christine Newman at AARP New Jersey about specific caregiving tips and information during COVID-19. So really grateful for all of our presenters throughout the whole series, and again for our sponsors and for all of you for joining us. So just want to remind you to sign up for those if you haven't already. There we go. And if you do want to learn more about the New Jersey Foundation for Aging, if this is your first encounter with us, please do visit our website and look for more information there. And be sure to check out our TV series, Aging Insights. There's a new episode up this month regarding online gambling, and so we encourage you to check that out. And if you have any questions, please do reach out and let us know. But we hope to see you again next week for the next installment in this series. And thanks again to our presenters for sharing your time with us today, and to all of you. So hope to see you all again soon.
Thank you.
Thank you. Bye-bye, Melissa.